بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنتكلم عن المانجمنت in details أو clinical pearl management of any patient with glomerulonephritis and how to safe prescribe all medication of GN for any patient with glomerulonephritis. نتوكل على الله. بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. صدق الله العظيم. اللهم صل وسلم على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. Our objective today to review acute and maintenance immunosuppressive therapies used for treatment in glomerular disease. This is our objective, the first objective, and the second one, brief overview of adverse effects associated with immunosuppressive therapy, discuss monitoring and safe prescribing practice for immunosuppressive therapy. Our contents today: introduction and cases. Introduction therapy, corticosteroid will start by that, and cyclophosphamide, rituximab. Maintenance therapy, and we'll start by C9 calcineurin inhibitors and antimetabolites, and eculizumab will give a hint, and the COVID-19, how we can prescribe safely any medication in COVID-19, some question and summary at the end. For introduction, a variety of immunosuppressive therapies used for glomerular disease. Various level of response to treatment, significant adverse effect of immunosuppression require vigilance and expertise when prescribing. تكون حذر وعندك خبرة في البريسكرايب الميديكيشن for any patient with GN. Understanding safety important. You should understand what is the safety important for each medication you will prescribe for any patient with GN. When to treat and when don't treat. When to treat patient with high risk for end-stage disease or mortality from his disease. Alternative therapies and significant symptoms need to treat this patient with immunosuppression. And when don't treat patient with low risk of progression to end-stage disease, or you have alternative therapy or minimal symptoms. When to wean immunosuppression and when don't wean. When I wean my immunosuppression, mild initial presentation, not well tolerated, expensive, and other therapies. When don't wean immunosuppression, severe initial clinical presentation, well tolerated, low risk of chronic toxicity, evidence of prolonging remission. This before we decide to treat any patient with GN diagnosed in your clinic or your hospital, just you should do screening and prophylaxis with immunosuppression in any patient with GN disease. Like hepatitis B, I will do hepatitis B surface antigen antibodies and or antibody. Hepatitis C, I will do anti-hepatitis C antibody. HIV, I will do anti-HIV. And latent tuberculosis, you should do tuberculin test, chest X-ray to rule out, or interferon gamma already assay. Also, we can do that. Strangulioids is common in our countries. You should do anti-strangulioids antibody to rule out this, because this will do bad complication after you immunosuppress your patient, and this maybe will invade or infect the liver and will do horrible complication or lung. Vaccination, pre-immunosuppression, you should receive any live vaccines for any patient before starting the immunosuppression, because after that you should avoid the live vaccine during and within 4 weeks of starting the immunosuppression. You should have at least 4 weeks or 1 month to 2 months before starting an immunosuppression after live vaccine. And you should don't forget also infection prophylaxis like transplant, BGB or pneumocystis jirovecii, pneumonia by either by bacterium or septa or dapsone or atuvacune or inhaled pentamidine. You can use any prophylaxis for BGB pneumonia. And candida, we can use clotrimazole, or we can use nystatin or weekly fluconazole, whatever you like, but we like already nystatin, this oral oral drops 1,000 or 500,000 unit per oral every 6 hours. This as regard infectious prophylaxis, TB pneumonia and the candida, and other prophylaxis like osteoporosis should use calcium and vitamin D. Don't forget this for this two bone prophylaxis plus or minus bisphosphonate if the patient develop osteoporosis, and the gastroprophylaxis like H2 inhibitor. We don't like them on PI for risk of acute interstitial nephritis. You can use H2 blocker like ranitidine or famotidine according to availability. Now this infectious screening, you should screen your patient before starting to be safe. Prescribe immunosuppression for any patient. Infectious screen. Number 2, infectious prophylaxis. Number 3, other prophylaxis like prophylaxis and the GIT prophylaxis. Put this in your mind when you prescribe any patient, any immunosuppression for your patient. Start by case number 1, 39 years, a female patient with bipolar disorders presenting with nephrotic syndrome 2018. Proteinuria around 3 grams per day and serum albumin 20 grams per liter. Significant edema, biopsy confirmed minimally changed disease, may have been taken NSAIDs around by that time. History of bipolar disorders controlled for many years on valproic acid. Case number 1, prednisone is resulted in complete remission with good response. As we know, minimally changed disease will respond all to prednisone or corticosteroids, but with a significant psychiatric side effect, mood swing, manic episodes, significant depression, insomnia, and unable to work. Corticosteroid initially intended for replacement therapy following bilateral nephrectomy in 1960. Reversal of acute rejection also 1961. Current indication of corticosteroid, we are using a pulse steroid in any patient with acute rejection in kidney transplant. Pulse steroid in many induction protocols. We are using already in the induction protocol, especially for L-thymoglobulin. Early oral steroid is almost all protocols. Starting any patient with acute interstitial nephritis and kidney transplant after pulse, we started by any patient with acute cellular rejection after pulse, we started direct oral. Steroid withdrawal increasingly implemented. Steroid-dependent graft, we'll see that. What is the mechanism of action? This is the steroid block cytokine gene transcription, anti-inflammatory. Block cytokine gene transcription, anti-inflammatory. Inhibit translocation of NF-κP. This is the factor or protein or receptors just little bind the antigen by T cells already inhibited by steroid. Inhibit the activity of dendritic cells and the P cells. Well-known side effect for the steroid metabolic either lipidemia, hypertension, hyperglycemia, and osteoporosis and the vascular necrosis. All these are metabolic side effect of the steroid. And I mentioned the bone osteoporosis, a vascular necrosis, and the cataract by long-term use. Cosmetic, also cosmetic feature, as we'll see next slide. The weight gain also from steroid. Systemic steroids used for acute treatment of GN disease. Indication RBGN. We are using an RBGN as a pulse steroid and the maintenance 1 milligram per kg direct after pulse steroid in ANCA vasculitis and TGBM, systemic lupus and lupus nephritis, pulses as a bolus and then oral by high doses. IgA nephropathy, same, especially with IgA with crescentic form. Minimally changed disease if severe proteinuria and generalized anasarca. Focal segmental glomerulosclerosis also we can use. Systemic corticosteroid block cytokine gene transcription, inhibit translocation of NF-κP, inhibit activity of dendritic and beta cell, synthetic analogs of the natural steroid hormones produced by adrenal cortex. Corticosteroid involved in carbohydrate, fat, and protein metabolism, anti-inflammatory, immunosuppression, anti-proliferative, vasoconstrictive, all this mechanism of action of the corticosteroid. And regarding mineral, this corticosteroid, mineralocorticoid part of the steroid produced by adrenal and affect ion transport in epithelial cells of renal tubules, regulate electrolyte and water balance. This mineralocorticosteroid. Corticosteroid diffuse passively across the cellular membrane. No need energy to be transferred inside the cell or outside the cell. This is passively diffusion and bind to the intracellular glucocorticoid receptor to effective gene transcription. Bind to and block promoter sites of inflammatory genes, interleukin 1 alpha and interleukin 1 beta. Promotes gene coding for anti-inflammatory gene product 1 GABA beta alpha interleukin 1 receptor 2 lipocortin and other interleukin 10 and secretory leukocyte protease inhibitor inhibit synthesis of inflammatory cytokines. This is the mechanism of action and management of many inflammatory and immunologic condition. Properties and dose equivalent. Just I need you from this slide, just a conversion. If I have one patient kidney transplant or whatever gene with prednisone 5 milligram, but the patient came by COVID or came by flare, I need to shift the dose by infection or whatever. I need to, or patient can't take orally surgery, whatever. You need to convert the dose. If your patient on 5 milligram prednisone is equal to 20 milligram hydrocortisone and equal what I like more 4 milligram methylprednisone and 0.75 milligram dexamethasone. I think that the most common three now use the dexamethasone we are using in corona. My patient on 5 milligram prednisone, I will give 8 milligram or 6 milligram, whatever the amount of this 5 to 0.75, either 6 or 8 milligram, equal methylprednisone 4 milligram if your patient is unable to take surgery, or hydrocortisone 20 milligram. This is the most important. But 5 milligram prednisone, hydrocortisone 20, for methylprednisone 0.75 is dexamethasone. Well-known side effect, as we mentioned, metabolic bone cataract, cosmetic weight gain, as we mentioned before. And this has just potential to cause serious adverse and effect and complication associated with increased dose and deterioration. As we know, this anti-allergic, anti-inflammatory effect of immunosuppression decrease the pain, decrease the swelling, decrease stiffening, and the physical disability. But on the other hand, this will lead to increased cardiovascular risk, cataract formation, and hirsutism, skin thinning, this cosmetic part, and GI can do with non-steroidal lead to ulcer disease, weight gain, obesity, from fluid retention, edema, Cushing syndrome, impaired glucose metabolism, insulin resistance, beta cell dysfunction, neurological psychiatric symptoms like depression, psychosis, whatever. As regard on the bone, osteonecrosis, osteoporosis, avascular necrosis, and on the muscle lead proximal muscle myopathy, and the wound infection lead to delayed wound healing or whatever. And also this is almost of this side effect of steroid. Broadly used in nephrology, used in minimally changed disease and focal segmental membranous lupus nephritis, IgA nephropathy, immune complex mediated GN, associated vasculitis, anti-GBM GN, and with the main the three pillar of kidney transplants destroyed. Pre-treatment consideration, infection screen. You should, as I mentioned before, don't start any immunosuppression except after doing full screen for your patient. Infectious screen and malignant screen before any recommendation for any immunosuppression. Unrecognized and treated latent disease may flare when immunosuppression, example tuberculosis. Treatment should be considered either preceding or concomitant with immunosuppression therapy dependent on the urgency of the timing of immunosuppression. مش هيجي لك عين انتي جي بي ام وهتقول لي استنى ما نعمل سكرين، لا انت هتبدا التريتمنت وفي نفس الوقت تكون بدات كل الورك اب سكريننج فور يور بيشنت either from infectious side or malignant side. Latent tuberculosis screen for tuberculin skin test, interferon gamma release assay can be used also as a blood test. Rule out active TB symptoms, chest x-ray, sputum testing for acid fast bacilli for 3 morning sample. 4 months of rifampicin versus 9 months of isoniazid plus pyridoxine for peripheral neuropathy. Syphilis, hepatitis B, hepatitis C, HIV, you should screen that also. Strongyloids, this is the most important slide. Tuberculosis, syphilis, hepatitis B, C, HIV, and the strongyloids, especially in endemic area. Africa, Asia, South East Asia, Central and South American, resistance, peripheral or unexplained eosinophilia, you should rule out strongyloid. Any patient came for you with peripheral or persistence, peripheral eosinophilia, you should rule out strongyloids. Stool examination for ova parasite screening for IgG antibodies to strongyloids, empirical treatment with ivermectin in endemic area. You should do that by this simple medication and the cheaper medication. Immunization, immune response to vaccine may be inadequate in immunosuppressed people. Individuals who are fully immunized may remain at risk for vaccine preventable disease. Delayed vaccination, if the immunodeficiency is transient, serological testing is available and there is a clear antibody correlates of protection, measurement of post-immunization antibody titer to determine immune response and guide revaccination. Vaccinate family and the caregiver also. You should receive, like in COVID now, screen at, for example. Invasive pneumococcal vaccine, pneumococcal C13 pneumococcal vaccine followed by pneumococcal P23 vaccine 8 weeks later. Hemophilus influenza vaccine type A, 1 dose. Influenza vaccine annually. COVID vaccination, how many doses? At least 3 doses. Hepatitis B vaccine, 1 to 6 months. I think acquired complement deficiencies, example receiving eculizumab, should resist meningococcal vaccine and pneumococcal vaccine, influenza vaccine should cover all this vaccine. For varicella, especially varicella zoster, if negative, we should all have positive varicella zoster vaccine because most of us already have chickenpox or shingles when he's young. If your patient is negative, he should receive the vaccine, I think, receive 1 dose and 2 months apart, he will receive a second dose. And after 2 months, he can start his immunosuppressive therapy if not emergency. Varicella or shingles vaccine, the live vaccine, but now I think this is not, but Zostafax is not live vaccine. I think it's killed, but not live attenuated vaccine. But already any varicella vaccine better to be given for transplant before any immunosuppression at least 1 month prior, second dose to be 1 month prior transplant at least. Vaccination with live vaccine, measles, mumps, MMR, measles, mumps, rubella, varicella, rotavirus, yellow virus, varicella zoster virus are generally contraindicated when you patient post-kidney transplant or post-immunosuppression. Deferred until prednisone less than 20 milligram per day and or immunosuppressive agent have been stopped for at least 1 to 3 months. Live virus vaccine can be administered for patient who is receiving steroid therapy when administration is short term, less than 14 days, low to moderate doses less than 20 milligram prednisone, equivalent 2 milligram per kg per body weight, and long-term alternate day treatment with short-acting preparation, and maintenance of physiological dose replacement therapy. BGB or BCB prophylaxis and pneumocystis carinii or Giardiaca is potentially life-threatening infection. It's very bad infection. If you will see one patient, you will know this aggressive disease and maybe end by ICU admission and they shift all medication to IV medication, as we discussed before in our presentation in the BGB pneumonia after kidney transplant. Recommended prophylaxis if the plan for prednisone more than 20 milligram per day for at least 4 weeks. Misoprostol salva, this is Ciptra-1, single strength tablet, 80 to 400 milligram daily or double strength, but we usually are using this single strength one. Just 1 tablet daily forever. Will continue until you finish this your immunosuppression. If the patient self-allergic or any problem, you can use Dapsone 100 milligram daily, but need to check G6PD deficiency test. You should do that. And atovaquone, the second shot, 1,500 milligram per oral once daily, but little bit expensive. Or the least used, the bentamidine. Bentamidine we can use if the others are not available. Bentamidine 300 milligram inhaled already, using as a nebulizer maybe every month, every 4 weeks. Bentamidine. Consider discontinuing prophylaxis when a prednisone dosage is stable less than 20 milligram. You can at that time discontinued prophylaxis. This is a picture, as we know already. This is a side effect of steroids. This is from first year of medical school. Cushingoid, weight gain, distribution of adipose tissue is buffalo hump like this, moon face, muscle wasting, and the proximal muscle myopathy, and this stretches marks from obesity, and weight gain and obesity, easy browsing, and the skin bone thinning, and decrease in libido, menstruation change, and hirsutism. All this a complication of side effect of steroid with truncal obesity, muscle atrophy, acne, thinning skin, berbera, wound healing, impaired wound healing, and this to magnify the side effect. As we know all, hyperglycemia, 20 to 50% among all people with no diabetes history, more common with risk factor for diabetes, elderly, overweight, a family history of diabetes, gestational diabetes, previous steroid-induced hyperglycemia. And worse, glycemic control in pre-existing diabetes treatment, oral preferred for rapid onset, target postprandial hyperglycemia. We can use glycoside, ribaglinide or insulin, basal insulin like glargine or NPH insulin with prednisone. Generally improves with dose reduction and usually reverse when steroid therapy is discontinued. Then go on to develop over treatment. Cardiovascular disease risk, steroid therapy may increase the risk of cardiovascular disease, as many patients with underlying inflammatory condition aggressively manage cardiovascular risk factor for all patients who are taking steroid. Hypertension and dyslipidemia. Hypertension, routine blood pressure monitoring, consider intensive target for patients with CKD, and dyslipidemia, LDL less than 2. This is the main risk factor for cardiovascular from steroid. As regards the bone health, stimulate osteoclastic activity initially in first 6 to 12 months of therapy, followed by decrease in the bone formation by suppression osteoplastic activity and decrease in osteoblast function and the lifespan. This is a side effect of steroid or osteoporosis, decrease the activity and decrease the function of the osteoblast and the lifespan, and promoting the apoptosis of the osteoblasts and the osteocytes. This is the main side effect on the bone. Increased fracture risk was independent of the patient age, gender, and underlying disease. Osteonecrosis, higher risk with long-term corticosteroid therapy, routinely assessed for hip, knee, shoulder pain, femoral or humeral heads, or go. Calcium and vitamin D used as a prophylaxis for this osteoporosis or side effect from the steroid in the bone. Don't forget, when you prescribe steroid, don't forget calcium carbonate plus vitamin D 1000 at least daily. And this diagram for bone health and osteoporosis, calcium and vitamin D, lifestyle modification, low risk, no further treatment, high risk, we can use this bisphosphonate as we discussed before. Peptic ulcer disease, systematic review on whether the use of systemic corticosteroid associated with increased risk of ulcer complication and GI bleeding or perforation, included randomized control trials, only 159 studies. Risk was increased from hospitalized patient with hazard ratio around 1.4 and very low absolute occurrence of GI or perforation in ambulatory care, not statistically significant. PI prophylaxis, perhaps if other peptic ulcer disease risk, more than 65 years old, the history of peptic ulcer disease, non-steroidal use, smoking, alcohol use, history of Helicobacter pylori infection, bisphosphonate or other medications that increase peptic ulcer disease. Those patients will be high risk, little bit high risk. Ocular complication, increased risk of glaucoma and cataract, risk of post duration and dose dependent, reversal of ophthalmology for comprehensive ocular assessment. Psychiatric, as we know already, most of our patients after starting high dose steroid, especially in ICU or after ICU or after kidney transplant, you will see that memory impairment, agitation, anxiety, fear, hypomania, and insomnia, irritability, lethargy, mood ability, panic disorders, and even psychosis. We saw many cases after kidney transplant from high dose steroid, especially after rejection of it following transplant. short course of urea and long-term therapy, depressive symptom, reduce dose of steroid if possible for patients with persistent symptoms, especially where steroid cannot be tapered. An anxiolytic can be used, antidepressant, antipsychotic therapy, maybe psychiatric consultation better, patient admission for self-harm or suicidal thinking. And as we know, what means by adrenal suppression, you should suspect any patient post-kidney transplant, post-GN treatment, and he's before steroid. You should suspect maybe patient non-adherence. High dose of exogenous steroid will do suppression to ACTH. It will stimulate our adrenal to secrete corticotrophin releasing hormone, LSTH, and the cortisol. All this will be affected when the patient already started by high dose of exogenous steroid. If the patient is stop or non-adherence to his medication, this will lead to this adrenal syndrome. By the criteria of adrenal syndrome, as we know, fatigue, nausea, vomiting, diarrhea, muscle weakness, weight loss, hypoglycemia, and depression with hyponatremia, hyperkalemia, metabolic acidosis. All this and this will be characteristics of this adrenal insufficiency. Steroid tapering recommended if taking doses of prednisone more than 20 mg daily for more than 3 weeks, or clinical sign of Cushing syndrome. No specific taper strategies. Reduce prednisone by 5 mg every week or every 2 weeks according to the severity of the disease. More rapid taper if side effects is horrible, like uncontrolled diabetes, uncontrolled side effect. And just about in your mind, just decrease to 5 mg once weekly. As this protocol, you can follow also if you like, according to the body weight and the weeks here. And this from 50, how you can decrease from 50 to 25 second weeks, in the third week 20, but after that you can decrease either by 5 mg, 2.5 mg according to the severity of the disease. Cancer screening, individual risk factor of symptoms suggestive of malignancy, age appropriate malignancy screen, colon. Any patient more than 50 years, you should screen for colon cancer, breast cancer. Any also patient age between 50 to 70, you should screen before mammogram at least. And cervical pap smear for any woman more than 50s also, or maybe at age 21 and 25. Maybe should screen every 3 years, and the pap smear test is validated for 3 years, especially for kidney transplant or CAP. The lung also screen just although chest X-ray and maybe low dose CT chest, especially if heavy smoker or any lung problem or strong family history. Infectious risk, don't forget infection risk will give GB prophylaxis. Don't forget to start your bacterium or receptor as a prophylaxis. TB you should screen, strongyloid you should screen, hepatitis B, C, zoster virus or varicella zoster virus should be screened before transplant. Risk for infections, increased doses. Now patient on high dose after receive pulse steroid before treatment, and the recurrence after that, this patient will be now under heavy immunosuppressed dose of steroid. The risk of infection, advanced age, diabetes, and hypoalbuminemia, especially both of severe uncontrolled diabetes and severe hypoalbuminemia. Corticosteroid, just don't forget to prescribe calcium and vitamin D with the steroid for osteoporosis prophylaxis. Consider bisphosphonate if high risk, if prednisone more than 0.5 mg per kg for BGB prophylaxis. Appropriate taper, generally taper over 30% of the time they were on to prevent adrenal insufficiency. Faster taper is typically 5 mg per week. Faster taper, 5 mg per week, some over 2 weeks, 3 weeks, whatever. Case number 1, this patient already in 2019 experienced a relapse of hair nephrotic syndrome. What would you treat with? What would you advise here? What is the next step in treatment minimally change disease if your patient have relapse and the patient compliance and adherence to her medication? What is the second step to add for this patient? And second step, don't take a long time. This CNI is a second line for minimally change disease relapse, which continues with low dose steroid. Some patients can't able to base this medication, can use low dose of myfortic with low dose steroid, and you will see a response. But the better combination is low dose steroid and with the CNI according to last recommendation or guidelines. Case number 2, 25 years male, presented March 2, 2022 with vomiting, hemoptysis, AKI, serum creatinine 450. As I presented one anti-GBM, interesting case already in our hospital. And I present this case from A to Z as in, I think is hot clinical case or emergency case in our presentation before. If you like to go back to hear how we can deal with anti-GBM or RBGN case. AKI, serum creatinine 450, CT chest, this multifocal consolidation, kidney biopsy at a local center and transfer to Centro to General Hospital. Anti-GBM more than 8 is high, and bronchial lavage confirmed pulmonary hemorrhage. What you will do? Usher syndrome, this is your diagnosis. Treatment should include pulse steroid. You will give 500 milligram IV for 3 days, then continue 1 milligram per kg per day. And at the moment, as soon as possible, you should start the plasmapheresis, and at least 4 or 5 cycle or 7 cycle, at least 7 cycle for this patient, and you will see response. And cyclophosphamide, you should discuss the issue for cyclophosphamide, especially this patient is young. And concerning regarding fertility here, fertility and concerning with cyclophosphamide. How would you proceed with counseling and the treatment? If there is anything else that would impact your treatment decision, how you can deal with this question now? A cyclophosphamide indication is indicated in ANCA vasculitis we are using before in one patient. Anti-GBM should mean therapy in anti-GBM and Usher disease, lupus nephritis in patient is known already, RBGN as we mentioned, steroid-dependent nephrotic syndrome, membranous nephropathy, all this with new cyclophosphamide. This adverse effect, as we know, bone marrow suppression, it is known already for cyclophosphamide, especially leukopenia, thrombocytopenia, and infection is high risk for infection. Also, you should screen your patient before and give prophylaxis with cyclophosphamide. Don't forget, don't give any patient cyclophosphamide without BGB pneumonia infection prophylaxis. Okay, and the candida also. Hemorrhagic cystitis, you should screen your patient by cystoscopy before any kidney transplant. You should ask your patient TGN or lupus nephritis kidney transplant workup, and you should do cystoscopy to rule out hemorrhagic cystitis before kidney transplant. Infertility is a side effect of this also. Pathogenicity and the malignancy also mentioned on cyclophosphamide therapy. Cyclophosphamide and the malignancy, because his mechanism of action direct DNA damage and reduce the immune surveillance to pick up or killing this pick up our malignant cell. Malignancy age and the 6 standard index rate around 3.4. Risk highest for cumulative dose more than 36 gram. Risk high for that malignancy more than 36 gram. Cumulative dose less than 10 gram associated with squamous cell carcinoma. Cumulative dose less than 10 gram associated with squamous cell carcinoma. Pontifical region, cumulative dose around 12 to 13 grams for 75 kilograms male. Assume normal renal function and age less than 70. We can use that. Cyclophosphamide and fertility, depending on the age, 6 cumulative dose. From keeping cumulative dose under here at the age of dose, if the age less than 20, just the cumulative dose should not exceed 20 milligram. Otherwise, will end by fertility, or this dose with this age will increase the risk of fertility. You should use this or this dose or lower than this. Patient to pubertal males not seen until dose more than 30 gram. You can see after that infertility. Sexual mature males 75 milligram. According to azoospermia, if more than 30 grams you receive, this is 100% you will get azoospermia. In comparison, by less than 7.5 grams is zero azoospermia. They have the problem with this cyclophosphamide and fertility. Prescribing appropriate dosing based on estimated GFR and the age, 25% reduction with estimated GFR less than 30, 25 reduction. 25 reduction in age more than 70 years, 25. Don't forget this 25, 25. 25 reduction on estimated GFR less than 30, 25 reduction when age more than 70. Generally, we are giving orally. For most of our patients, we'll give in orally, not IV, at least better than IV, and no. And as by the studies out trials already done for that, no difference between IV and the oral. Milligram per kg for oral doses. When prescribed with tapering dose for prednisone. Should do CBC bi-weekly, twice weekly to monitor for severe myelosuppression, cytopenia. Dose titration as appropriate. Clinical response may be delayed. This number 2, would you treat this patient? When would you don't treat this patient? When you will you decide don't treat this patient? I will treat this patient, but when you will decide to treat this patient? If you will do kidney biopsy and show severe crescentic or fibrotic crescentic GN or severe EFTA, what is the benefit of treatment? Just to give the patient the risk, or there is alternative therapy? Anything else what you will do? I will not treat if 100 fibrotic crescent or severe EFTA. We are able to arrange, as this patient is lucky because we are able here at General to arrange sperm banking while he is in patient adolescent, and the YAS program started cyclophosphamide after that sperm banking. Case number 3, 62 years male diagnosed with BLA2R positive membranous nephropathy, November 2018. After conservative management, 1 year, proteinuria more than 6 grams per day. Problem started November 2019. Initially, borderline proteinuria 3.5 grams per day. Relapse June 2020. CT scan reveals a nodule in the left apex that that had progressed from previous active smokers. This patient active smoker now. 62 years is positive R2 phospholipase antibodies to receptors, positive membranous nephropathy November 2018 after conservative management for 1 year, proteinuria more than 6 grams. The problem started 2019 with borderline proteinuria now 3.5, relapse June 2020. CT scan nodules, active smoker. What you will do? I wanted to avoid treatment with cyclophosphamide, prednisone, given malignancy risk. Now, is malignancy risk? You should avoid any cyclophosphamide in your mind. What are the conservative method approach to this GN? Would there be concern treating with rituximab for this patient? Okay, this patient 62 years. Rituximab. Come to rituximab now because we have cyclophosphamide, and this will give you a high risk for malignancy because this finding of chest X-ray. Rituximab monoclonal chimeric antibody against CD20 found on surface B cells, approved for treatment B-cell lymphoma. As a part of the sensitization protocol, treatment of antibody-mediated rejection, and with another refractory IgN cases, and not an approved indication. This chimeric monoclonal to CD19, CD20 in the beta cell, and not in the plasma cell. Indication ANCA vasculitis, steroid-dependent nephrotic syndrome, membranous nephropathy. Rituximab is doing a great job with ANCA vasculitis, steroid-dependent nephrotic syndrome. Either we can use an ANCA vasculitis, steroid-dependent nephrotic syndrome, and membranous nephropathy. What is the adverse effect? Infusion reaction, severe allergic reaction if happen. With I saw 2 patients already with allergic reaction, just decrease the infusion rate. Because you already given anti-prophylaxis, anti-anaphylaxis before therapy, you should give. Don't forget a steroid and antihistaminic and paracetamol or acetaminophen before infusion. Infections complication is there, and we not see more, but he's doing severe hypogammaglobulinemia, especially if you will treat pregnancy lady with recurrence membranous nephropathy during the pregnancy. If you will give her rituximab, your baby will be born with hypogammaglobulinemia and will be high risk for any infection after delivery, and it will end by late onset neutropenia as a side effect from rituximab. Black box warning for this lymphoma, patient with lymphoma, and concomitant chemotherapy, hepatitis B reactivation. This is another side effect. Now, infusion reaction, infectious complication, hypogammaglobulinemia, late onset neutropenia, and the black box warning for the promyelocytic lymphocytic leukemia or lymphoma and concomitant chemotherapy and hepatitis B reactivation. Those 300, we are giving already 5. Usually we are giving 500, and 2 weeks apart we'll give another dose, and infusion should be over 8 hours, 12 hours, but I think 8 hours is okay. 1 to 4 doses according to response or your plan or guidelines. Side effect, as we mentioned, allergic reaction should be covered by diphenhydramine, acetaminophen, and hydrocortisone or methylprednisone before الانجكشن. في يعني hepatitis screen because it lead to fatal hepatitis, not fatal hepatitis screen should done before. Progressive multiple leukoencephalopathy, it is rare. Progressive multiple leukoencephalopathy, if the patient delirium confusion after that, don't forget this male multiple leukoencephalopathy. Rituximab prescribing induction or maintenance dose 1 gram or 500, either 1 gram or 500. We're usually using 500. Pre-medication as I mentioned, methylprednisone 100 milligram IV, diphenhydramine 50 milligram IV, acetaminophen 1 gram oral. Methylprednisone 100, diphenhydramine 50, and acetaminophen 650 milligram or 1 gram per oral. Start infusion at rate 50 ml per hour and titrate to 400 ml per hour. Infusion for reaction and immediate to assess. Just if you start anaphylaxis or anything or any signs of allergy, just decrease the rate to 20 ml per hour or 10 ml per hour and then increase gradually until the patient will be adapted for that. What about malignancy risk for rituximab? Always a theoretical risk with immunosuppression and patient lower malignancy risk than cyclophosphamide. Similar malignancy risk to standard population. Rheumatoid arthritis or rheumatology patient, no increased risk of malignancy, similar rate to standard population, and non-Hodgkin lymphoma, no evidence of increased secondary primary malignancy. It means malignancy risk is low with rituximab in comparison with cyclophosphamide. Monitoring may check CD19 or 20 after a few months to see if depleted or no. You should check, but monitoring rituximab, I will do CD19 to check depletion for this or no. Labs in 1 to 3 months post. Early assessment of ongoing symptoms from infusion reaction. You should observe at least the first hour after infusion. Like other immunosuppression, close follow-up in clinic, not necessarily required, no tapering or adjustment. Test number 3 after discussion with the respirology, received rituximab March 22. The close monitoring of the pulmonary finding. We discussed already this case with the respirology because this lung nodules and the respirology just told this low risk of malignancy or exacerbation of air malignancy. Just start your treatment and will close monitoring with a bronchoscope and with the radiology. And next one, this calcineurin inhibitor, as we mentioned here, this we'll discuss later in our transplant presentation, immunosuppression. Maybe I will prepare after this presentation. These are the 3 signals for activation of our T cells. That's antigen presenting here to T cell CD4, and this will activate calcineurin, will end by activation this in nuclear factor T cells here, NEVATs. And this will end by interleukin activation, interleukin 2, but by the end from activation our nucleus and T cells nucleus here. Calcineurin inhibitors, this is the main mechanism of our calcineurin to inhibit this activation of this NEVAT. And calcineurin is a phosphatase. Calcineurin is a phosphatase. Dephosphorylates regulatory protein allow entry into a nucleus. Dephosphorylate regulatory protein to allow entry into the nucleus. Calcineurin inhibitor bind to a specific protein. بدل calcineurin is a phosphatase. بيعمل dephosphorylation here to regulatory protein to enter the nucleus. Calcineurin inhibitor bind to specific proteins. Cyclovilin bind to cyclovilin, cyclosporin bind to cyclovilin, and the tacrolimus binding to FKP. drug protein complex bind to and inhibit the calcineurin. Net result decrease cytokine production and lymphocyte proliferation. Here will end by decrease the lymphocyte production and the T cell activation or proliferation. As we mentioned here, cyclosporin and the efficacy. This is the T cells here, and this is a nucleus here. And this cyclosporin will go to cyclophilin and inhibit this phosphorylation protein here, inhibit this nuclear fat and nuclear fat activation. And this bile tacrolimus will bind by efficacy 506 here receptors, and this will end by complex here. This will inhibit any fat activation to nucleus, and this will inhibit the T cell proliferation. Cytokines inhibited by by C9. This cytokines interleukin 2, interleukin 1, interleukin 2 and 1, 4, interferon alpha, gamma, others. And the problem here is the difference between cyclosporin and the tacrolimus. Cyclosporin will increase expression of TGF beta. This TGF beta, this increase, for the pathogenesis of CKD, as we discussed before. When you have more TGF beta, this will increase fibrosis in our kidney. So we prefer the tacrolimus over cyclosporin, because the cyclosporin will end by increase this expression of TGF beta and increase the fibrosis in our kidneys. Calcineurin inhibitor inhibit T cell activation and proliferation, but also have a direct effect on the podocytes. Indication of C9 already membranous minimally changed diseases, especially in steroid dependence or refractory nephrotic syndrome. طبعا lupus nephritis, as we know, with multi-target therapy. Now inhibit T cell activation proliferation, inhibit T cell activation proliferation, but also have direct effect on the podocyte. Here will go to action of C9, can be used in membranous GN or steroid dependent refractory nephrotic syndrome, and lupus nephritis with multi-target therapy. Side effect, as we mentioned before, in our electrolytes has base disturbance and hyperkalemia, elevated creatinine and potassium from Winkel channel rule, and hirsutism and gingival hyperplasia, and hypertension, hyperlipidemia, glucose intolerance, and neurotoxicity. The main side effect of calcineurin inhibitor, AKI or AKI-induced CKD or progressive CKD, hyperkalemia and hirsutism, and gingival hyperplasia, hypertension, and hyperlipidemia, and glucose intolerance, and neurotoxicity. Acute decrease in the GFR from vasoconstriction on the afferent arterioles, thrombotic microangiopathy, especially with the C9, chronic non-progressive decrease in the GFR, chronic progressive decrease in the GFR, chronic interstitial fibrosis from increased TGF beta factors, hypertension, and sodium retention, tubular dysfunction, hyperkalemia, as we mentioned before in the hyperkalemia, hypomagnesemia, hypophosphatemia, hyperuricemia, mechanism of C9 toxicity, acute toxicity reversible from afferent arterial vasoconstriction, arterial vasospasm, renal hypoperfusion, chronic toxicity reversible from renal hypoperfusion, obliterative arteriopathy, focal ischemia from interstitial fibrosis or EFTA, tubular atrophy, and glomerulosclerosis. And here's the picture of this afferent arteriole here, and you'll see afferent arteriole after using CNI. This will be, and with the glomeruli looks healthy here, but looks here dark from fibrosis, and this afferent arteriole vasoconstriction. And this is the mechanism of calcineurin inhibitor, alwin kinase with no lysine, and this is sympathetic nervous system stimulation, endothelin 1, angiotensin 2, nitric oxide. All this is the mechanism ended by hypertension from vasoconstriction, and increase the reactive oxygen species, and decrease the vasodilatation, and this will end by this one kinase will end by this sodium chloride co-transporter channel lead to activation. One kinase activates this channel, lead to more sodium reabsorption. This inhibit this, and this lead to sodium chloride reabsorption, lead to end by hypertension, and this also all lead to vasoconstriction, will end by hypertension, and decrease vasodilatation from decreased nitric oxide. All this will end by hypertension. The mechanism of C9 induced hypertension, either from the wing, and this will go to sodium chloride channel in activation, lead to more sodium chloride reabsorption, and lead to more salt and water retention, and this will lead to hypertension. Sympathetic activation, vasoconstriction, endothelin 1 vasoconstriction, angiotensin 2 reactive oxygen species. All this vasoconstriction, decrease nitric oxide, decrease vasodilatation, and the ball. All this mechanism of side effect from calcium inhibitor on vascular tone, sympathetic nervous system, all end by this is a mechanism of hypertension with C9 induced hypertension. This is a common question. Will ask you what is the mechanism of C9 hypertension? Wink, don't forget the wink, and activation sodium chloride co-transporter and distal convoluted tubule, more sodium chloride reabsorption, and sympathetic nervous system. This is number 2. Endothelin 1 and angiotensin 2 will by increase the reactive oxygen species. And the nitric oxide decreased, lead to decrease of vasodilatation. Toxicity of tacrolimus versus cyclosporin, non-renal toxicity, reported difference in non-renal toxicity with tacrolimus as compared to cyclosporin. More prominent in neurological side effect with whom لما البيشنت يجي لك العياده بتريمورز معناها ان في تاكروليمس توكسيستي. نوت تاكروليمس وهيدك تريمورز وهيدك ده مع التاكروليمس اور فريجو nuanced diabetes after transplant. It's also with tacrolimus, more frequent diarrhea, dyspepsia, vomiting. We can see also with tacrolimus, more frequent alopecia with tacrolimus, hirsutism, gingival hyperplasia, and hypertension with C9 cyclosporin. With the cyclosporin, تمام. يبقى tremors, headache, we can see with tacrolimus, nuanced diabetes with tacrolimus. More frequent diarrhea, dyspepsia, vomiting with tacrolimus, more frequent alopecia with tacrolimus, and less frequent some hirsutism, gingival hyperplasia, hypertension, all this with cyclosporin in addition to tacrolimus, but not cyclosporin has rarely been reported to induce hypertrophic cardiomyopathy and severe neutropenia. This with tacrolimus, severe hypertrophic cardiomyopathy and severe neutropenia. Acute C9 toxicity, when you will see just only this facularization of the renal tubules, this is clear now. This is a picture of C9 toxicity if no signs of rejection. Here, no signs of rejection, no arthritis, no tubular capillary C4D staining, no glomerulitis. All these signs of cell rejection or acute antibody-mediated rejection. Only if this only tubular facularization, like we see this is the pathogenomic for acute C9 toxicity. These other strips of these are nice characteristic strips of chronic C9 toxicity. You will see here no normal tubules in this side. In this side here, you can see these damaged tubules with interstitial inflammation, damaged tubules with interstitial inflammation. And again, you will looks like you will see here again, these normal tubules. This means a strip of EFTA here, interstitial fibrosis and the tubular damage in the middle, and on the periphery of the biopsy, you will find normal tubules. This is the characteristics of chronic CNI toxicity. Chronic CNI vascular damage, also the criteria of this CNI toxicity. Side effect, extrarenal hyperlipidemia, cyclosporin more than tacrolimus, and hyperlipidemia, hyperglycemia more than a cyclo, hirsutism with a cyclo, alopecia with a TAC, neurotoxicity, headache with a cyclo, tremors with a TAC, mental status reversible, posterior leukoencephalopathy, bone pain, mental you can see reversible, posterior leukoencephalopathy and bone pain, gout, يسموها البريس syndrome, posterior reversible leukoencephalopathy, and the gout and the infection malignancy. You can see with the both. And this gingival hyperplasia maybe need surgical treatment or need to shift the cyclosporin to tacrolimus or other medication. And with this gingival hyperplasia, clinical criteria or clinical picture or pathogenic of cyclosporin toxicity. white matter hypodensities on CT and MRI reversible already after stopping this normal one. And this the white matter hypodensities, this leukoencephalopathy, reversible leukoencephalopathy after stopping start to be normal again. Cyclosporin dosing, some said 5 to 10 milligram per kg per day. You can give every 12 hours, available in 25 milligram increments of level or C2 level, but we prefer in cyclosporin to do CT to catch this. I think C2 is C2 means 2 hours after a dose, 2 hours after a dose. Of level means 30 minutes or 1 hour before a dose. If you will decide to give IV, you will give a third of those. If, for example, if you have one patient receiving 150 milligram BID, means 300. 150 milligram BID means 300 daily. I will give 500. Give 100. This is a 1/3 of the dose. IV, these are 50 BID or 100 IV continuous infusion, whatever. الدوز بتاعت السايكلوسبورين ما تنساش في الترانسبلانت او في الجين والكلام ده كله من 5 ملغ either in الجين or 10 ملغ or reach 10 ملغ in الترانسبلانت. We are given a dose divided every 12 hours. And the top level I will check C2 level common better after dose by 2 hours. I will take the blood level to the better time for the area under the curve to reach your therapeutic level. I will check your therapeutic level and will come now. If I will use IV cyclosporin, I will give third of the dose of the oral. We have immediate release and prolonged release Prograf, this immediate release tablet capsules, and Advagraf, this prolonged release capsule. Advagraf, this once daily Prograf should be used ID and will give the dose 0.1 to 0.2 milligram per kg per day. If I use Prograf, I will use 0.1 milligram per kg per day. If with the Prograf, immediate release, with the Advagraf, this prolonged release, I will use 0.2 milligram per kg per day. We'll use high dose with the Advagraf because use once daily. Higher dose required with the Advagraf, as we mentioned, available in 0.5 milligram increment, 0.5, 1, I think, and now 3. And the best we are trained, all centers now I trained and just using TRAV level. What means by travel? C0. TRAV level is 30 minutes or 1 hour prior morning dose. تمام. Urine, prescribing membranous nephropathy, lowest effective dose, steroid dependence, minimally changed disease, focal segmental, target TRAV level. Cyclosporin, as we know already in GN 100-150, this TRAV level. And tacrolimus 4 to 8, this will be 4 to 8, it will be perfect or less than 8, 4 to 7, 4 to 5, that's will be okay. Can increase the C9 level. الحاجات اللي بتزود لك السي 9 ليفل سايكلوسبورين وتاكروليماس اريثرومايسين ازول زي الانتي فانجل انتي ديبريسنت دلتيازيم فيراباميل. لو عيان هايبرتنشن فبتحاول تظبطه بالدلتيازيم والفيراباميل عشان تقلل السي 9 دوز. لو العيان عايز اكسبنسيف وبتاع تديله فلوكونازول او انتي فانجل تو ديكريز السي 9 كوست. الاميدارون اولسو بتزود السي 9 ليفل. الحاجات اللي بتقلل الليفل زي الريفامبيسين انتي تيوبركلاس انتي بليبتيك، الحاجات اللي هي كومون انها بتقلل الليفل زي الريفامبيسين and الكربامازيبين فينوتوين will come to that. Monitoring, check potassium creatinine like we are giving ASR best to our patient. Just check potassium and creatinine within a couple weeks. We check with the dose increase, any dose increase at any time. You should check within 1 week or 2 weeks your potassium and creatinine. Clinical assessment for other adverse effect like neurotoxicity. Drug interaction, as we mentioned, drug decrease the level of C9 like antituberculous, antiepileptic, like rifampicin and barbiturate, phenytoin, carbamazepine, steroid also decrease the level. Other side effect, take care when you prescribing also to safe prescribe, don't prescribe haphazard. Statin like Ator or Lipitor or Simvastatin, whatever. Or whatever you will prescribe, care you prescribe small dose 5 milligrams, the lowest dose 5 milligram, 10 milligram. Don't increase more than this because it's high risk for rhabdomyolysis, especially if the patient came by myalgia. Don't forget patient came transplant or GN on steroid or any immunosuppression and you will give him medication and he came complaining of muscle pain, myalgia. Just check your medication, statin. aminoglycoside and amphotericin also added more nephrotoxicity with this medication. Take care when you prescribe amphotericin or for fungal infection or aminoglycoside for gram-negative bacilli. And sirolimus added with CNI will add more nephrotoxicity. Take care from that. As we mentioned, if you need to increase your level, if your patient you are given high dose C9 and still no level, just calcium channel blocker like verapamil, diltiazine, antifungal like fluconazole, or any antifungal macrolides, erythromycin, protease inhibitors, and the grapefruits juice. This will increase the level. Case number 4. 84 years, female with history of mild dementia, admitted with short breath, summer 2021. Found to have AKI and serum creatine 250 micromole and subnephrotic proteinuria, subnephrotic. Renal biopsy revealed C3G successfully treated with prednisone and MMF, tolerate MMF well. We're now 84, dementia, short breath, AKI, creatinine 250, subnephrotic proteinuria, renal biopsy C3G successfully treated by prednisone and MMF, tolerate MMF well. Case number 4, currently she remains on my 4700 BID and the prednisone 5, May 2022, creatinine 134 from 250, okay. And GFR 29, serum albumin 41, urine albumin creat ratio is 1 milligram from subnephrotic range of proteinuria before, that's good. And hemoglobin 87, I think from around 110 or 100, 110 on presentation. Little bit leukocytosis, platelet is okay, and LDL is 2.1. Now this patient is still on my 4700 BID and zone 5 by this creatinine, albumin, hemoglobin is little bit low. Here, what would you taper her immunosuppression? How would you approach to her low hemoglobin? Would her CKD be accounting for anemia? This patient just the hemoglobin drop here, just anemia. Now, how you can deal with this anemia for this patient? Either this patient from CKD here, anemia related to CKD, or anemia related to this myfortic because he's doing myelosuppression with the main 2 causes here. I will come now to answer this question. Don't forget that we'll answer this question for by end of our discussion. Mycophenolate azathioprine, mycophenolic acid, reversible, the mechanism of action, reversible inhibitor of inosine monophosphate dehydrogenase. Reversible inhibitor of inosine monophosphate dehydrogenase required for de novo purine synthesis, does not interfere with salvage pathway, also has activity against B cell. Don't forget this IMPH, reversible inhibitor of inosine monophosphate dehydrogenase. Azathioprine, prodrug of 6-mercaptopurine, purine analogs. This prevent DNA synthesis and de novo purine synthesis, and we'll come to that. Mycophenolate movetil, this a group added to prevent breakdown in the stomach. Movetil group added to prevent breakdown in the stomach. Celsep MMF available in oral or IV formulation. Enteric-coated mycophenolic acid, myfortic, we are giving to patients who can tolerate this oral MMF. We are giving this myfortic, this enteric-coated mycophenolic acid. With anti-metabolites, what is anti-metabolites agent interfere with the synthesis of nucleic acid and inhibit proliferation of T cells. Proliferation of T cells and the B cell lymphocyte, and so suppress post cells humoral immune response. This is the mechanism of action here on the cell cycle for this MMF or azathioprine. This inhibit cell proliferation, T cell proliferation, and we'll come to that. MMF or mycophenolate movetil, this will be distracted to mycophenolic acid, this is the active form. And this MPAG, this is the inactive form. This mycophenolic acid active form will be transferred by this enzyme to MPAG, this inactive form. This will be excreted in biliary and renal. But this part may be recirculating again intrahepatic recirculation by bacterial glucuronidase into active form. So this patient, especially with a cyclosporin patient, this part will be inhibited in a cyclosporin patient, not in a tacrolimus. So in a cyclosporin, you should give high doses, a little bit high dose of mycophenolic acid, because this will be inhibited and will decrease this mycophenolic acid, ZAC form, not with the tacrolimus, but with the cyclosporin. Again, MMF, mycophenolate mofetil, will be destructed or بيحصل له utilization and reduce this mycophenolic acid. This is the active form. This is the active form by intrahepatic metabolism by this enzyme. Glucuronolase transferase will be transferred to MPAG. This inactive form, this renal excreted biliary excretion, but this part of biliary secretion will enter into by this bacterial glucuronidase inside the liver, will be transferred to active mycophenolic acid. This will be inhibited with the cyclosporin, so we need to give high dose with the cyclosporin. Mechanism of mycophenolate, don't forget this mechanism. This is exam question. Mycophenolate mofetil, what will do? He will inhibit enzyme monophosphate dehydrogenase here. This will inhibit this transformation of all this, and this will end by inhibition of cell cycle activation and proliferation. Again, here's the same diagram as we mentioned before. Here, azathioprine will be transformed to mercaptopurine here, and this will be inhibited. This 6-uric acid will be this mercaptopurine will be transferred to a 6-uric acid by lexancine oxidase enzyme. If we have allopurinol here, this will be inhibited. This will increase this mercaptopurine here, and this will lead to azathioprine toxicity. This is a mechanism when you are patient receiving allopurinol, lexancine oxidase inhibitor will prevent transformation, this metabolism of azathioprine mercaptopurine to 6-uric acid. This will lead to accumulation this mercaptopurine here, and this is the same side effect of azathioprine. You should decrease any patient with azathioprine and he will receive allopurinol. We should decrease the dose by 25%, 50% if you can. Okay, this lexancine oxidase inhibitor will inhibit this transformation of the azathioprine mercaptopurine metabolite here to 6-uric acid, and this will end by don't forget this enzyme also. We need to, any patient you will prescribe azathioprine, you should check this enzyme before you prescribe azathioprine for any patient. This thiopurine methyltransferase TPMT. And you should check this TPMT before that. This will end by toxicity from this azathioprine. This anti-metabolites affect the rate-limiting step of purine synthesis for beta and T cells, include mycophenolate and azathioprine. Indication of anti-metabolites we are using commonly in lupus nephritis and induction and maintenance, second line agent for maintenance of ANCA and other GM as a second line. As we mentioned before, in the first case, minimally changed disease, البيشنت can't pay or expensive for her. لو السي ان اي غالي على المريض عندك وعندك ام ام اف ممكن ياخد، ما عندكش خيارات ثانيه، ممكن تدي له العيان وتشوف الريسبونس. مايكوفينوليت ادفيرس افكت، طبعا من الكومن ادفيرس افكت المايكوفينوليت جي اي، نوزيا، diarrhea, most common, pathogenic, bone marrow suppression put in your mind. If the patient start to develop anemia, leukopenia, just think in the mycophenolate. In the kidney transplant, if you see CBC with cytopenia, whatever, or leukopenia, just think in mycophenolate or myfortic, think in the valganciclovir, think in Citra, all this, think also in the pantoprazole. I also can lead to leukopenia. Take care from that. يبقى now adverse effect, nausea, diarrhea is the most common, teratogenic, bone marrow suppression, anemia, leukopenia, and infectious risk, herpes zoster virus, CMV, and herpes simplex also, the risk factor from mycophenolate, the proliferative. And not so to be significant risk of hepatitis B, C, BGP pneumonia. Mycophenolic acid toxicity, as we mentioned, GI intolerance, not related to local effect, not clearly related to mycophenolic acid area under the curve, nausea, esophagitis, gastritis, we saw many patients, diarrhea, we saw many patients, no real difference between formulation, hematological bone marrow suppression, leukopenia, thrombocytopenia, anemia, is common than with azathioprine. As we mentioned, GI intolerance, diarrhea, not related to local effect, not closely related to this again, and again, same the previous slide. With those, I will give MMF or mycophenolate mofetil 1 gram BID or enteric-coated mycophenolic acid 720 milligram BID derived from islet cell with cyclosporin lower dose with tacrolimus. derived from this trial with cyclosporin lower dose. يعني الدوز with tacrolimus بتقللها، لكن مع cyclosporin بيحتاج هاي دوز عشان الميكانيزم اللي احنا شرحناه قبل كده. Azathioprine 1 to 2 milligram per kg per daily, and if we will give IV here, we'll give half a dose. Just don't forget cyclosporin. If I'm giving cyclosporin IV, I will give third of the dose. If I will give azathioprine oral and I need to give IV, I will give half a dose, not third dose. Third dose with the cyclosporin, half a dose with the azathioprine. Don't forget that. Prescribing induction versus maintenance dose, myfortic 1080 milligram, mycophenolate 1500 milligram. Ideal dose may vary with genetic background. Mycophenolic acid level to guide therapy have not been widely adopted now. Available two forms, as we mentioned, Celcept, mycophenolate mofetil, and myfortic, اللي هو mycophenolate sodium. This enteric-coated. If my patient started on Celcept, I think it's cheaper in our countries and they can give him BID. If the patient starts vomiting, nausea, gastritis, diarrhea, I will shift it to myfortic and we'll see. If persistence and refractory and impossible to tolerate, I will shift to azathioprine. Mycophenolate after checking BMT enzymes. Mycophenolate monitoring CBC and liver enzyme every 2 to 4 weeks initially. CBC, liver enzyme, any patient with recent transplant or GN, you should check CBC and liver enzyme every 2 weeks at least, especially in GN, maybe twice per week in post-kidney transplant. But here, CBC and liver enzyme every 2 to 4 weeks initially. Don't forget CBC, mycophenolate, cytopenia. Then every 1 to 3 months, closer follow-up with those change. لو انت هتغير الدوز, if you will decrease or increase the dose, you should check CBC and liver enzyme. Liver enzyme, CBC. Liver enzyme, CBC. Mycophenolic acid exposure increase during the first year post-transplant, affected by renal function, serum albumin, and the choice of CNI. As we told you, cyclosporin will decrease the level of mycophenolate. You should choose high dose of mycophenolate with the cyclosporin. Suggests mycophenolic acid exposure of 30 to 60 milligram for effectiveness, but not for toxicity. Conflicting result of randomized control trial, therapeutic drug monitoring of mycophenolic acid not now. Sirolimus, same mechanism, just bind to tacrolimus, bind to FKPB, and same target on as tacrolimus, but he will go to inhibit mammalian target of rapamycin emitters, prevent cytokine-dependent paracell proliferation by blocking progression of from G1 to S phase of cell cycle proliferation, and fibrotic properties, less nephrotoxic compared to C9. And we mention here this already will go to emitters inhibitor and inhibit cell proliferation and cycle. And they will go here, sirolimus here, go to bind by FKPB, but he's willing to go to inhibit the emitters here, and this will inhibit the cell cycle. This other mechanism for sirolimus will go to bind by FKPB receptor, not like tacrolimus, but these will go to another way, not calcineurin or nifat. Will go to the emitters and inhibit the cell cycle proliferation. And sirolimus doses once daily. We have a sirolimus already, can use the ID, but little bit expensive. Sirolimus once daily should not be taken at the same time of cyclosporin, can be taken with tacrolimus. Long half-life monitor every weeks, and because it's 36-hour half-life, you can monitor just only every weeks. Monitor trough level, C0 level like tacrolimus. The C0 level or trough level means 30 minutes before the morning dose. This more recent level, that's 4 to 8. Before is 15 to 25 is high toxic dose already, but already like tacrolimus 4 to 8 as regard the level in the blood. Sirolimus toxicity, this is aggressive nephrotoxic syndrome, if used with the C9, recovery from ATN should not prefer the post-kidney transplant, also compared on the healing, and leukopenia, thrombocytopenia, also hyperlipidemia, pancytopenia, impaired on healing, delayed recovery from ATN, nephrotoxic with the C9, nephrotoxic with C9, delayed recovery from ATN, impaired on the healing, leukopenia, thrombocytopenia, hyperlipidemia, pneumonitis is common, proteinuria is common, TMA, especially in combination with C9, will increase the risk of TMA. Our case 4, we need to search why patient in mycophenolate or myfortic and started to hemoglobin drop. Etiology for decrease hemoglobin may be multifactorial, either from MF or decrease GFR. Myfortic dose decreased to 540 BID from 720 BID, and we consider RNAs for this patient at the next visit, and the patient improved after that. Case number 5, 54 males with history of minimally changed disease, then ANCA vasculitis. A typical presentation, minimally changed disease and ANCA vasculitis after receiving induction with cyclophosphamide had been maintained on azathioprine for years, decreasing hemoglobin from 130 from 13 to 9 or 130 to 90, and some fresh platform referred to GI for that issue for hemoglobin drop. But now this patient already ANCA with minimally changed disease, received the induction with cyclophosphamide and maintenance azathioprine for years. Just observe it now in the clinic, hemoglobin drop from 130 to 90, referred to GI, found hemorrhoids and mild peptic ulcer disease on scope, on upper scope. Liver enzyme starting to rising to 500. Liver enzyme started to rise also, anemia and liver enzyme. Azathioprine, purine antimetabolite, as we mentioned, indication maintenance therapy in ANCA vasculitis, second line therapy for other GN. Maintenance therapy in ANCA and second line therapy for other GN. If not tolerate the MMF. We need the azathioprine used if the patient can't tolerate, if the patient can't tolerate neither MMF or mycophenolic acid. If the patient tolerate neither MMF or nor mycophenolic acid, the patient can tolerate these two medication. Mycophenolate is not used for female recipient of childbearing age unless they are long-acting contraception. You can use 2 contraception for that female. Have undergoing surgical sterilization procedure or have absolute infertility. Mycophenolate is teratogenic and its use is contraindicated in pregnancy. Thus, in this patient, azathioprine is preferred, which does not seem to have a detrimental effect on fertility or pregnancy. Adverse effect, no vomiting, diarrhea, hematological toxicity, severe bone marrow suppression, especially with azathioprine, hepatotoxicity also, and infectious risk. As a side effect, we have hepatotoxicity and the hematological as well. Our patient anemia with liver enzyme is elevated. Azathioprine, hematological myelosuppression, hepatitis, cholelithiasis, pancreatitis, interaction with allopurinol. Reduce the azathioprine dose by 25 to 50% and monitor your CBC. As we mentioned, myelosuppression, hepatitis, cholelithiasis, pancreatitis, and reduce dose again 25 to 50% to monitor CBC count weekly at the start. Azathioprine testing for thioprine as methyltransferase TBMT. TBMT enzyme you should screen before starting azathioprine if available in your hospital. Main enzyme for inactivating toxic product. This is the main enzyme for inactivating toxic product of azathioprine. If this enzyme deficient, this toxic product will increase the toxicity from azathioprine. This inactivate the toxic product of azathioprine. This enzyme, thiopurine S-methyltransferase TBMT. A patient with this mutation should not be given azathioprine. However, severe reaction may still occur in those with TBMT mutation. Dose them on 1 to 2 milligram per kg per day. IV doses will give half a dose. Start with low dose and titrate up. Start slow and go up. and lab every 2 to 4 weeks. Initially close clinical follow-up gene labs, maybe 8 months or 3 months follow-up. As a Azathioprine bioavailability, 50% amount absorbed by oral form. Dose 1 to 2 to 3, 1 to 2 milligram per kg once daily, that's enough. Non-dialyzable, non-renal excreted, and no monitoring, only CBC and liver function test. CBC and liver function. Don't forget this azathioprine CBC liver function test. Case number 5, our case. How would you approach this patient with elevated liver enzyme? لو جالك عيان وانت ماشي على السيوبرين او لقيت له معاه liver enzyme, and we attribute entirely to azathioprine, should they receive other maintenance therapy for their ANCA vasculitis? If the patient quiescent or receive 2 years or 3 years, you can stop. And as regards elevated liver enzyme, you should rule out virology as hepatitis B or hepatitis C or HIV. Rule out hepatitis virology screen and liver ultrasound to rule out intra-liver problem or maybe steatohepatitis, maybe problem in the portal veins. And drug toxicity disease is the last differential diagnosis if you rule the other 2 possible differential diagnosis. And decision to made for this our case number 5 to stop azathioprine, receive maintenance therapy for about, she already received the maintenance for about 3 years, and the guidelines recommend 1.5 to 2, and now currently recommend for 4 years. No additional immunosuppression prescribed. The renal parameters continue to remain stable and renal function subside down to normal. Just one word to eculizumab. This humanized monoclonal antibody blocking cleavage of complement C5. This will inhibit the complement C5 indication for atypical HUS and C3 glomerulopathy. With eculizumab, humanized monoclonal antibody blocking cleavage of complement C5. This is indicated in atypical HUS and C3GM. Adverse effect, as we know, you should vaccine your patient for meningitis, pneumonia, influenza before giving the eculizumab. It will end by encapsulated organism like Neisseria meningitis and the Streptococcus pneumonia, Haemophilus influenza infusion reaction rare to occurs. You should prescribe before to save prescribe eculizumab meningococcal vaccine, serogroup B, monitor for disease progression, quadrivalent vaccine. Many still provide antibiotic prophylaxis even with vaccine like penicillin 300 milligram BID. And this, some doctors ask why penicillin or azithromycin or ciprofloxacin as a prophylaxis with eculizumab. This you should receive for this streptococcus pneumonia and Neisseria meningitis, and all this you should receive as antibiotic prophylaxis, penicillin 300 milligram BID or azithromycin ciprofloxacin if allergy to penicillin. COVID-19 consideration vaccination timing with respect to rituximab. I'm during this COVID era now, and I need to prescribe rituximab for my patient, and the patient not vaccinated. Just provide 3 to 4 weeks prior. You should receive your vaccine at least 4 weeks prior to rituximab dose, or delay vaccination at least 3 to 6 months post rituximab, according to the American College of Rheumatology for COVID vaccine. Please just follow these guidelines till now. 1 month prior dose or 3 to 6 months after rituximab, you can give your COVID vaccine. Prednisone dose less than 20. Infection generally hold the cyclophosphamide prednisone. Case by case discussion. This according to low prednisone 20. I think it literally should be decrease the prednisone to be safe to give, and the patient not going on infection, and generally hold the cyclophosphamide prednisone during this COVID vaccine. We'll go to some cases. Regarding testing trial involved in treatment patient with IgA nephropathy. Testing trial IgA nephropathy with corticosteroids, which of the following significant adverse effect was thought to be the reason for the testing trial was terminated early. What do you think? What do you think is this question in testing trial? Why is terminating early? For hepatitis B reactivation from steroid with IgA nephropathy, or TB activation, or hepatitis C, or BGB? What do you think? Why testing trial in IgA nephropathy terminated early? I think the best answer here is BGB pneumonia. Second question, observational study and controls clinical trial have suggested A patient treated with the rituximab have been known to be experience all of the following adverse effects. Rituximab have all the adverse effect, all this except fusion reaction is common, increased rate of malignancy or hepatitis B reactivation is common, late onset neutropenia is common, but increased rate of malignancy, as we mentioned before, is low with the rituximab. Patient treated with ocrelizumab may be at risk of the following all bacterial infection except Streptococcus pneumonia, as we mentioned now, will give prophylaxis penicillin or allergic azithromycin ciprofloxacin, and Neisseria meningitis, Haemophilus influenza, all this is a risk factor except this Streptococcus biogenes, they are not a risk, but not a bacterial risk factor post ocrelizumab. And patient who became pregnant, MMF, mycophenolates, and limitours, all this should be avoided during the pregnancy and shifted to azathioprine, as we mentioned before. The effective in all chronic patient on chronic immunosuppression as infectious, malignancy, toxic, metabolic, cosmetic. This is a side effect of immunosuppression collected here: viral infection, fungal, bacterial, malignancy, lymphoma, skin, toxic, renal, and cardiovascular, metabolic, diabetes, osteoporosis, hyperlipidemia, cosmetic, hirsutism, and acne. All this is a side effect. And we collected here also hyperlipidemia, sirolimus, hyperglycemia, stachylomas, malignancy, lymphoma depletion, infectious, corticosteroid, hypertension with tacrolimus, cyclosporin or C9, general chronic kidney disease also with cyclosporin mainly, more than the tacrolimus, and the proteinuria common with sirolimus, and the hyperlipidemia with sirolimus. Clinical pearl, a variety of immunosuppression medication are used in GN. Understanding mechanism action is crucial. Proper use medication are used in combination to reduce the recurrence, relapsing rate, improving long-term graft survival, and mitigate side effect. And therefore, additional more reading for our GN, and you should learn more for GN saving prescription, how to manage your GN without doing harm for your patient. And this more reference for immunosuppression post-transplant to know more details for about immunosuppression medication to save prescription and to know side effect more. واتمنى يا رب تكونوا استفدتم، واسف على الاطاله، ونسالكم الله التوفيق والسداد، ولا تنسوا دائما الصلاه والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. نترككم في رعايه الله وحفظه، والسلام عليكم ورحمه الله وبركاته.